Dr. Pam.
And I'm Nurse Rena. So, Pam.
Yeah.
I had another patient come in last week.
Mm-hmm.
Literally, she got to the point of crying because we were able to talk about menopause, and a lot of the knowledge I got was, listening to you. And then she was crying just because she felt like I'm not alone. This is normal, what she was going through.
Right.
So I'm wondering if you could recap the symptoms that women will get.
Yeah, because there are a lot of them, and everyone knows about some of the ones like hot flashes and night sweats, right? Those are pretty common. Hot flashes vary per women, but most women have like a kind of a neck to face flush, and they get really hot. For other women, they have just like a heat intolerance where they're just really hot when everyone else is comfortable. And then the night sweat, some people wake up literally soaking wet and have to get up and change their pajamas and things like that. And other women just hot or a little bit sweaty. In fact, I had that happen to me last night. It wasn't very fun. Yes, and I realized I had to put my patch on for a long time. I'm a bad patient. But anyways, so those, everyone knows about those. But I think some of the other symptoms are less talked about, and that is the mood problems.
Big time.
So for a lot of women, they feel down, like they do have the crying, and just that horrible down, even a depression. A lot of women have anxiety, which is the worst, right?
I think
even women who don't.
I think you're right. I think anxiety, huge. Depression, huge.
And then, or just psycho moodiness, right? Where you're one day, like when my kids were, made my countertop have a little etching on it, and I just lost my mind. And then they look at each other like, oh, she's crazy.
Yeah,
and then that makes you lose it even more.
I know.
And then the next day I was like, I was Looney Tunes. So those moments too, where you're just a little bit overly sensitive. And then also back and forth, like crying spells, crying at the dumbest commercials, and then being angry and irritable. And we talked about that. For some women, that triggers marital problems, right?
Oh, me.
Because especially if you don't know, if you don't know that it's hormonal and you just think you're losing it, and then your family and your husband especially thinks you're losing it. It's not fun, right? And they take it personally.
Or for me, I felt like I didn't know that I wasn't acting normal, right? I just knew I didn't feel right. And then I remember hiding things. I was so embarrassed that I even had to take the hormones. And I was almost like, oh my gosh, I'm getting older. I hid things. It was so weird. Yeah. I kind of described it as having an IV, and like I was on like a drug until you helped me. Yeah. Hey, try this. Right. Try that. Yeah. Yeah.
And yours was a little more drastic because you had your ovaries taken out, and that is sudden, and it's harder. It's much harder.
But I like what you said though. That just triggered.
Yeah.
The one thing that you always say with the hormones is basing it on how you're feeling, and I just will never forget that. We would try something and you'd say, how do you feel?
Right. Because some people measure numbers, and I always say, who cares what the number is? The number could look really low, and you may go, but I feel great, so why would I raise your dose? I wouldn't do that.
Doctors do.
Right. Yeah. But I don't go by a number because women are different, and some women feel better at higher levels, and other women, the only time I check hormone levels anymore is if a woman doesn't respond to normal things, and I'm like you, why aren't you responding? And then you find out that when you check levels, some women are very fast metabolizers of estrogen, or maybe they're not even absorbing it properly, right? And so you find that even though you have them on these great doses of things, they're not absorbing it, so it doesn't show up. And when you check their level, you're like, oh, wow, it's like you're not even on anything. Yeah. Otherwise, I mostly go by how women feel.
But we'll go back in. But what I want to give everybody, again, the doctor discusses what is, perimenopause and what is menopause. But just to recap the symptoms again.
Yeah.
So,
hot flashes, heat intolerance, night sweats, moodiness,
yes,
anger, irritability, anxiety. And then
depression.
other ones, yep. And then other ones like fatigue. Like I mean,
yes.
just where you just wake up and you're like, I'm exhausted. And some of that can be related to insomnia, which
Correct.
is another
That's
symptom.
Another one.
Insomnia, fatigue, and joint pain.
Right. And then you mentioned the exasperation. Let's say I was saying like the bug bite, and you're like, well, what is that again? The exasperation?
Yeah, so it's like menopause, like if you have a known illness like lupus, for example, women will have worsening flares, especially before they even hit menopause, when they're perimenopausal and the hormones are a little bit up and down. It will exacerbate any things you're already trending towards. Like, so if you already have achiness, it'll make that worse. If you already have some moodiness, it'll make it worse. Yeah. So it kind of brings out any things. If you have like gut issues sometimes too, women, especially when they're perimenopausal, which is where they have periods, but they still have symptoms of menopause. And most of the symptoms come before their period comes, right? So they'll go, oh yeah, before my period, I'm psycho, I have hot flashes, I have night sweats, my lupus flares, or my depression flares, or my gut gets totally messed up, like Crohn's disease patients or ulcerative colitis. So it kind of does bring out some of the areas of your body maybe that are already having issues, and then it will exacerbate those things. So yeah, fatigue, insomnia, joint pain, sometimes just general body aches women will have. And then you find out they're related, because they used to say those weren't related to menopause, because then if you do treat someone with hormones, they'll go, oh my God, my joint pain went away, or my fatigue's improved.
Right.
And so, and then some of the studies they did looking at that timing hypothesis that we talked about last time, which is if you take hormones within 5 to 10 years of menopause, you can get the benefits without the risks, and it does help the brain and help the heart and all that. That in those studies, they also were looking at symptoms, and that's when they finally admitted, oh yeah, women are not as moody, and they sleep better, and all those other, they maybe don't have joint pain as much. I had a patient like that. We had her go off of her hormones because she was, at that point, she was in her 60s. And I said, well, why don't you go off and see if you even need it? She called me and said her joints flared so badly that she swore it had to do with going off. And so we said, well, let's restart it and see. And she said, night and day difference. And she decided to stay on them forever, because she just said, I don't want to ever feel that way again.
Yeah.
So those types of symptoms, for sure. And then, definitions are confusing, because a lot of women feel like they're in menopause, but if you're still having periods, even if they're not regular, that's perimenopause. But the symptoms can be just as bad or worse sometimes, because you're like up and down and all around.
So that's why our first menopause, podcast, we really do talk about that. So
yeah,
if you guys need to listen to that.
Yeah. And then by definition, menopause is 1 year of no periods. And then you can say, oh yeah, you're definitely menopausal because you've had 1 year of no periods. Now you can figure out 6 months in, a lot of women go, I think I'm there, because they feel the difference. Mm-hmm. And then you go, yeah, you haven't had periods, you're probably there, right? So anyways, yeah, so what can be done about it?
That's right.
Right?
What do you...
And last time we did go over some of the risk factors
of
hormone use, like with the breast cancer
and
things like that. And we do think hormones can lower colon cancer. They definitely lower risk for fractures and things like that. So the question is, what to do? So the first thing that is really important is, even if your whole life you've had kind of a crappy lifestyle and you eat processed foods and you eat too much sugar and you do the bad oils and you just don't exercise consistently, you won't do well even on hormones. You have to like say, okay, wow, my body is asking me to help it now. And now I have to be exercising. I have to eat the healthiest food I can eat. And, you know, the best diet is a diet that's very low in sugar. Some people do better on a, you know, gluten-free diet. Some people don't. Mediterranean diet. Paleo, Whole30 thing. Yes. It depends on your gut, you know, but any kind of a low sugar, no processed food diet is key. And then if you're not moving, you got to move your butt. And we're going to do a whole podcast on that because that is huge. Yes. If you want the worst joint pain, you want to put on more weight because, weight gain is a huge. Oh, yeah. We forgot it.
That's right.
Weight gain is a big symptom. And hair loss. Yes.
Oh, God, that's so mean.
I don't know who came up with this, but they say we lose about 20% of our hair.
I believe it.
With menopause. And then we forgot that one. And then weight gain. Yeah. Because even if you were eating the exact same thing every day and you hit this menopausal time, you will put weight on. You have to shift down to eating less or whatever.
And then what we will get into is, huge we lose resistance muscle. Training.
Yeah.
We
lose even more muscle. And then we have more cortisol, so we end up putting on a little more in the gut, which...
because of lovely stress and anxiety. Yes.
Yeah, and menopause makes it even go up higher. So, so that is key. That's the first thing to start with is, like, if you don't have any of those good habits, you have to do those. And then a lot of women are stressed and have issues with, living in that fight or flight stress symptoms. So some kind of quieting is important, I think, like meditation, right? Yeah. If you're not doing some kind of mindful, and we'll do a whole thing on that because, I love my meditation or yoga's quieting, gratitude journals, which have science to back up that they really do help us. All those things are very important because if you're not going to work on your mind and help your mind have better thought patterns, you're not going to do very well, right? So some kind of quieting is important. And then if women are still struggling, and a lot of my patients, by the time they have come to see me, they have tried things like black cohosh and ashwagandha and ginseng and some of those things that do have benefit for women. And they are just saying, I can't live this way. And it's about quality of life. So if someone comes to me, they're doing all these healthy things already. They've tried all these different other products that you could get over the counter. And they say, I can't live this way, my quality of life is horrible, then they're a candidate for hormones. And like I said last time, back before we knew how to extract estrogen from things, women would get so desperate they would do just crazy things like, take pig ovaries and pulverize them and try to drink them down because they were so desperate. So now we know how to extract the hormones. So then that's a person, like if you say, oh yeah, my quality of life is terrible, I need something, and you're a candidate for hormones. How do I know if someone's a candidate? Well, number one, they can't have had a blood clot to the lungs. Then it's a contraindication. Although I have a funny story about that. Because I had a patient who came to me and she was on Premarin, and she was on the highest pill form that you could get, which pill form increases the risk for clotting factors. So I was like, well, she had a history of a pulmonary embolus or a blood clot to her lungs, which could be fatal. And I said, who gave you these hormones? Because you're not supposed to be on them. And she goes, I lied. She lied because she felt so crappy off of them. I said, but you know that, a blood clot to your lungs can kill you. She goes, yeah, I don't care. So what I did for her is I said, okay, I lowered her dose and I put her on a non-pill form, because if you take a pill, it goes through the liver and it increases clotting factors. But we know from studies that some non-pill form products don't increase the clotting factors. However, there is a new estrogen product now that they say their form of estrogen, when you swallow it, doesn't change the clotting factors. So they have some data to show they don't increase the risk for blood clots. to the lungs. But anyway, but in general, if you've had a heart attack or a stroke, or if you've had a blood clot to the lungs, or even blood clots to the legs, you have to be very careful taking hormones. So, and history of breast cancer, right? So,
you mean the swallow, the pill?
No, just hormones in general. You're really considered to not be a candidate for hormones. Now, of course, there are women like that one. She had a blood clot to her lungs, and she said, "I don't care. I'd rather die than feel this crappy, and I'm willing to lie and try to get my hormones." So then you just try to make it safe for people. And there are breast cancer women who will, beg for hormones, and not everyone has a hormone positive breast cancer, like where the receptors on the breast cancer are stimulated by estrogen and progesterone, and especially in those patients.
Well, it's nice because now they can tell the difference.
Yeah, they can. But even then, their doctors will tell them, don't do hormones, right? Be very careful. And we talked about how in breast cancer patients, the vaginal dryness is a huge issue. So I will use the vaginal products because they don't absorb into the bloodstream. And you can monitor that a little bit, which I used to do. I used to check everyone's level to make sure they weren't absorbing it. And some studies have shown, even though the numbers are small, that breast cancer patients haven't necessarily had an increased risk doing that for sure.
And I love that you recap that because I can't tell you how many patients have been told by their doctors because they do vaginal estrogen they cannot take as systemic.
Right. Now, systemic for some women helps the hot flashes, the night sweats, the moodiness, and all that stuff we talked about. But it doesn't help their vaginas get
we
talked about that before. Yeah. So some people just will have to do both.
Yes.
But if you have someone who you're worried about taking hormones, like a breast cancer patient, but they need the vaginal help, those products are great. And then you don't do anything systemically, right? That absorbs into the bloodstream. So, so let's say someone comes in, they're not a risk factor. Another one that nobody talks about is alcohol use. If you are a drinker, first of all, it's so unhealthy to be a drinker. Like the people who come home and have the 1 to 2 to 3 to 4 every night, bad news bears, increases breast cancer risk. And also it's a sugar and it affects your gut, it affects your brain, it affects our sleep. Anyways, so if you have someone who drinks a lot, and I tell my patients, if you like to drink every night, I don't think you're a good candidate to take hormones because the combination of hormones and alcohol use ups that breast cancer risk. That's what I think. My theory is that it's one of the reasons some women have such a response to taking hormones with breast cancer. It's because we're not really telling them better watch the alcohol. And and of course people aren't going to admit.
And everybody, and right? I can't tell. I mean,
well,
I'm glad I don't, but so many people do.
Right. If you go home and have 3 or 4 drinks at night and you decide to take estrogen, you got to be careful. That breast cancer link is big. They did a study on teachers. Every night I wouldn't do it. Yeah. 3, as a guideline, we say like 3 times a week, maybe 1 drink, maybe 2 at the most. Wow. But you have to really watch that. So they did a study on teachers and they had them taking just the hormones and then they looked at the alcohol use. And if you were hormones plus alcohol use, breast cancer went up. Dang. So I always tell people, we don't talk about it enough.
No.
And so I tell my patients, I go, okay, you want hormones? Okay, you better move your butt and do some form of exercise. Walking's great. And then you better not be drinking every night because you're not a candidate in my view because I don't want to increase the risk of breast cancer. And then you better be eating healthier diet, right? Now, one of the things I wanted to mention quickly is my patients will go, can I lose weight on hormones? You for sure don't gain weight. Losing weight sometimes, but it's because women feel better, like they're sleeping better. And we all know that when we're tired and we feel horrible and we're achy, we're not going to go exercise, right? And you're less likely to eat healthy. You just don't care. You're like, I don't care. Right. So for sure, we have to make sure that we add that in as part of like, you want hormones, then you can't do that anymore. You have to find a way. But in that way, hormones could maybe affect weight, right? Because if you're feeling a lot better and you have energy and you're doing all the right, you're eating better and you're moving more, then it can make you lose weight. But you know, I used to hear those commercials where they go, yeah, take estrogen and lose weight. And I'd be like, doesn't work. Don't do it. Yeah, there was something like that. But okay. So then if they're a candidate for hormones and they don't have any contraindications, I did have a patient who had a heart attack and she came to me and she was taking hormones. And she didn't care and she wanted to do it and we went through the whole thing. Anyways, so then the question is, you know, what kind of estrogen do you want to take? We have there, you know, there's the whole thing that we mentioned, I think last time about bioidentical.
Yes. That people think it's better and doctors will say,
yeah,
you need to be bioidentical.
Yeah, and most products are nowadays bioidentical, and a lot of women don't think the FDA approved products are, but they are. Like the patches have always been bioidentical.
Yeah.
And then now, because of the fact that we can extract the estrogen from plants, almost all the products, the compounding pharmacy and the FDA products, they get the same estrogen, and they it's all bioidentical pretty much. The only one is Premarin that's comes from the pregnant mare's urine, like we talked about before. And otherwise, there used to be another one. Well, no, that came from plants, but technically it wasn't bioidentical. It was called Senestin. I don't even think it's around anymore. Anyway, so pretty much everything is. Okay, so the one advantage to the FDA-approved products is they get spot checked, and they have to be very consistent with how much estrogen is in the tablet.
Right. Yeah.
Where the compounding, if you have a good one, they can be great, but if you don't, it can be an issue. Anyways, so women then have to decide, do they want a pill? Now, we talked about that. If I have a younger, super healthy person who's super fit and they move and they don't have any risk factors and they go, look, I just want a pill. I don't care. It goes through the liver. It increases clotting factors, but their risk of a blood clot is so low because of their lifestyle. Then you could say, yeah, go ahead. There's the estradiol that's bioidentical. In the pill form, it's generic and it's cheap. So it's super cost effective. Now, the half-life of it usually comes in 0.5 milligram, 1 milligram, or 2 milligrams. The half-life is a little shorter than 24 hours. So sometimes women do better if they take one in the morning and one at night, which for me, I'm a horrible pill taker anyways. And if you try to get me to do something twice a day, not as great. So then you could say, okay, when are your worst symptoms? Oh, at night, you know, I want to sleep better. And then you could have them take it in the evening. But otherwise, sometimes I will do twice a day with that one just because of the half-life. So then you have patches, which are bioidentical, of course, like we said. And patches, the ones that I use the most are twice a week. There are a couple of patches out there where you change them once a week, but I think that those wear off a little bit towards the end, and the twice a week ones work a little better. That, when you look at steady state of estrogen, that one seems to keep women here, because think about it. If you take a pill, and then it drops over 24 hours, and then you take it and it goes up, and it, right? So you're kind of getting this. And so sometimes that'll trigger migraines in certain women. So then you go to just a good steady state. So patches are good for that. So patches twice a week, but they're like little Band-Aids. I use them. And sometimes you get the little Band-Aid ring, which is annoying, but sometimes I
use an adhesive.
Yeah, so you can use that, or anyway, so those can be good. Now, when you take an estrogen, if you have a uterus, you have to take a progesterone, because otherwise you could get a uterine cancer, right? So when women have a uterus, then we go over what the most common progesterone I use is the bioidentical, but I like it because it's micronized progesterone, and it can help with the hot flashes, the night sweats, and it can help women sleep. You have to take it at night because it can make you a little bit sleepy. But my insomniacs always go, really? It didn't affect me at all.
I would have been one of those.
So you would be like, what? It's supposed to make me sleepy? Anyway, so that is my favorite progesterone. Now there are a couple of patches that have progesterone, well, that have the progesterone.
Combo.
Yeah. However, they're hard to get sometimes, but it's a good product. There's some combination like combo patch that has both, but in general you kind of have to do separate these days. So if I had someone on the patch, I would say, which progesterone do you want? That one is the one I usually start with, and it's enough to protect the uterus. The problem with progesterone creams, like we talked about last time, is some women don't absorb them, and then they're not protecting their uterus. So you have to be so careful with the cream. So if I have someone on estrogen, I want them on the pill form of micronized progesterone. So there's micronized progesterone, you take it at night. Then if I have women who have a lot of, maybe they spot bleed, because the other thing, sometimes hormones will trigger some bleeding in women. Who wants that? That's the one benefit of menopause, right?
Right.
No periods. Why do you want to bleed? No, thank you. So then I would use a different progesterone, sometimes called norethindrone acetate. It's the progesterone that is in a lot of birth control pills. Norethindrone acetate.
Yeah, say that again.
Norethindrone acetate. The brand name, which is easier, is Agestin. It's Aygestin. But that one only comes in a 5 milligram tablet. And you don't need 5 milligrams in someone just to protect their uterus when they're on an estrogen. They do half a tablet. So I have them just cut those in half. That's another option. There's Provera, which originally, was with Premarin and Provera, and there was a combination called Prempro. I don't use it as much because it's a very potent progesterone, and I think it has more side effects and can negatively impact like cholesterol a little bit more than like the micronized progesterone. But some women just don't do well on the micronized. They wake up, they feel kind of a little bit dizzy or groggy, and they just don't do well on it, and I have to switch them over to so then I use the norethindrone acetate. And so
say those symptoms again, because I think, again, doctors don't tell patients. What was the symptom with the progesterone?
Oh, yeah. So for some women, they get really bloated. They get with the progesterone. Sometimes they feel like it makes them a little bit irritable, like the Provera. That's why I don't like it as much. They'll get bloaty, and they'll get more irritable, and they obviously don't feel good on it. Now with the micronized progesterone, the symptoms that you can get are in the next morning feeling a little groggy or a little dizzy. I had a couple people go, I just feel like I can't wake up when I take that, right? Or I'm a little dizzy, I don't like it. And then you have to switch them over. And then I usually use norethindrone acetate. So then there are gels and sprays and all sorts of cool things that you can use every day, right? There's the little Divigel packets that you can take off, and then you put the dose on your thigh and rub it in. And then there's the Evimus spray that's super convenient. And the only issue with those is cost.
Exactly.
And then there's Estrogel, you rub it into your arm. The cost can be very tough for some of the gels. I always try to get patients to do you can download a coupon from the company that makes it, or you can do something like GoodRx to try to bring the cost down. And those are great products. They're great products. That's the biggest factor is the women will go to get it, and it's so expensive, right? And sometimes they're hard to get. Like I've noticed with the Evimus spray, sometimes they don't have it in stock. And then your patient's like, well, what am I going to do? And you end up having to like try different ones. So they run out of those on occasion.
Can I do a side note, Ben?
Yeah.
It's so frustrating how insurance doesn't cover our hormones. It's so frustrating. Yeah. And I think it inhibits women from getting the care they should get.
Yes.
And I'm going to say this, and a lot of us women know, with the insurances, we don't get hormones, but the men will get their erectile dysfunction meds covered.
Well, and exactly.
That's my vent.
And then what happened too was with Women's Health Initiative, when they're like, hormones are bad, they'll kill you. Yes. A lot of the insurance companies go, especially Medicare. Medicare usually leads the way. Like if they drop something, all the other insurance companies go, well, then we're not going to pay for it either. So they started making it more difficult. And they did get a little backlash, and I noticed that now they will, but you have to sometimes go through, like, we have to get pre-authorization.
Isn't that crazy?
And it's so dumb, right? When
the insurance, they're dictating what you get to give your patients.
Exactly.
So crazy.
Yeah. So
sorry. So back to so progesterone.
So then you need the progesterone. If you have had a hysterectomy, you don't need one. On occasion, I have women who will say, I want it anyways. Well, the only thing is, like we talked about last time, if you use a combination of estrogen and progesterone, there's that slight increased risk of breast cancer, right? But women who had hysterectomies or only took estrogen did not have an increased risk for breast cancer. And in fact, they had less breast cancer than
That's in the
placebo
first one.
group.
Yes, that was such good info.
So I always say, why would you do that then, right? Like I've had a hysterectomy, so I just take my estrogen, and it's one less prescription too. But anyway, so yeah, and your doctor will know all the different products, and there's a combined pills that you can do as well. And one of the newer ones that I talked about is called Bijuva. They have that estrogen that's not supposed to increase clotting factor, so you could still use it in someone if they go, I really want a pill. The doses are a little lower, so if I have someone who needs higher dosing, then I would, and they don't do well on it, then you're kind of limited, right?
What about the pellets and the
pellets
things?
Because a lot of people talk about pellets. Yeah. Okay. So when I first came out of residency, in certain places they were using pellets, and the only downside to pellets is that after a while, people's levels would just suddenly go up, like 4,000, 5,000. I mean, crazy levels. So you have to be very careful with them, and then you're kind of stuck with whatever you're getting, for the month or 6 weeks or wherever you're getting it from. They implant it in the subcutaneous tissue, and then it puts out a little bit every day, right?
And then when they pull it out, so it I really don't know.
Yeah.
So they just slide something in, and it gets absorbed completely.
Yeah, and it puts out a little bit of hormone every day,
and then it just gets dissolved, and then you have to just get another one.
Yes.
Do they put it in the same spot different?
That I don't know, because I don't do them.
Right.
I'm not sure. I would think they do different place. But so that's the biggest issue. And I feel like women can get good management if their doctor's working with you, like, hey, how are you doing? And upping the dose if you need to, or, without having to do pellets. Because eventually, in shots too, sometimes like in women who had hysterectomy and you take their ovaries out, they're so symptomatic, and the stuff we give everyone else is not enough, and I have to give shots. And eventually, just had this happen last week or the week before. One of my patients was feeling horrible. She's like, oh gosh, I think, and she was like, she had, started shots again, or I don't know. She was doing them herself, and then I go, well, sometimes if your estrogen goes too high, you feel like it's too low. You feel terrible. You can't sleep. You can have hot flashes and night sweats. Her level was 4,000. And I go, it was too high. So we knew not to give her more. We knew that we needed to be careful with what she was taking, right? So anyways, I know that and then there's also women who have asked me about, there's a progesterone IUD, and that can protect the uterus. Like if you have one of those and you take estrogen, you don't need to do a pill.
That sounds good, because it's right where it should be.
And exactly. So it protects the uterus. It doesn't give you a lot of progesterone absorption. On occasion, I have patients who, no matter what kind of progesterone I give them, they hate it. They just said they don't feel good. There's a thing. There are some women who are very sensitive. That's a great option, and the only downside is insurance will not cover it for that.
Yeah, that just gets me
so,
going.
And they're $1,000. Now they last for at least, now they're saying Mirena can last at least 8 years, maybe longer. So in someone like that, you could get
insurance
benefit.
doesn't cover.
Right. But so if you have someone though who's super sensitive, then they would consider maybe paying for that. Because then if you break it down over the 5 to 10 years that you're going to use it and keep it with the progesterone coming out every day, that is more cost effective. But that's the downside. I think in Europe they use those, and I don't know if they're covered, but they use them a lot more in women with menopause to protect the uterus.
Because maybe their health system covers it.
Yeah, maybe. So here's the thing. We'll wrap it up now because we don't want to go too long.
Right.
Let's recap menopausal things next time and maybe go over some of the more non-hormonal.
Next week?
Yeah, because that way we don't lose people, because after a while you're like, okay, I'm menopausal. I didn't sleep last night. I got to go to bed.
But yes.
Right?
So
does that sound good?
I think the main message too, which I have to keep emphasizing, is someone that gets to have you as their doctor is so great, because people need to know they need a doctor that goes by how they're feeling.
Mm-hmm. Yeah.
More so than constantly looking at the labs.
Right. Now, I did check labs on that one patient, right? Because
but you won't say, patients will tell me all the time, I felt like this.
I don't treat a number.
Well, you don't, looks like you don't need it.
Right.
Because your labs.
Yes. Don't treat a number, you treat the patient. Especially in perimenopause. If you check those hormones, most women look great. Mm-hmm. And they're like, no, I don't feel good. Yeah. So you're treating the symptoms. And like I say, I treat patients, not a number. Some women will feel great at low numbers. I love that. They're feeling great at low levels of estrogen. Others, you need to get them up a little bit higher. Yep. So that's the key. And perimenopause, most of the time when I check their labs, they happen to be good that day, because it's
right.
And then you're not going to go, oh, you feel horrible and you're having hot flashes and night sweats on and off and you're moody and your husband wants you to disappear. Or you want to kill him.
I think that.
Then you're going to still treat that, right? You're going to still treat it. And it's a little different. Oh, so next time I want to talk, Lisa, can you mark that down? That's our sister, our producer. I want to also talk about the fact that, now I lost my train of thought. Oh my gosh, we really need to talk about it.
But we'll talk
levels.
Natural
What was
remedies,
it?
you said,
No, we're going to talk about natural remedies, but oh, I know, the treatments for perimenopause are a little bit different.
Ooh, okay.
Okay,
Good
they're different because if you give the really if you give really low doses, you won't touch them. So I don't want to forget about that.
Okay,
but we'll do that next time. But yeah, we're hoping that women are realizing that they're not crazy,
normal, they're not alone,
and there are things they can do to feel better.
Yes, exactly.
Yeah.
Okay.
All right.
Bye.